Now we will start with free PG paper session 1. I would request Dr. Balaji Mane sir, Dr. Bhushan Kulkarni sir and Dr. Bhalchandra Paike sir to chair the session.
Good afternoon everybody. Today I'll be presenting my paper on head neck fibrous dysplasia. It's a case series. Okay, so overview. This is the overview. These are the following topics that I'll be speaking on. So as introduction, fibrous dysplasia. It was first described by McCune and Brook and coined by Lichtenstein. So out of all the benign tumors, this constitutes of about 7%. And all the bone tumors, it's 25% of all the bone tumors. Malignancy is about less than 1%. It has a slightly female predilection. Also, it occurs in the first 3 decades of the age group, and as the age increases, by the time puberty hits, it's self-limiting. So, this is a sporadic, congenital, rare disease. It's benign and it's slowly progressive. Also, it can involve a single bone or it can involve multiple bones. It's usually unilateral, and the genetic changes that occur are on the somatic level in the GNAS gene, which codes for the alpha subunit of the G protein. So what happens is, regarding to this disease, there is osteoclastic hyperactivity, osteoblast, there is differential deficit, and also fibrous medullary proliferation. In the craniofacial fibrous dysplasia, what happens is the contiguous bones of the facial region are involved. So in this there are 2 types, as I already said. It could be monostotic and polystotic. In monostotic, it does not have any sex predilections. It's usually self-remitting at puberty. In polystotic, it has a slightly more female predilection. Also, it progresses even after puberty. So in the monostotic one, craniofacial bones that are involved, only 10% of all of the cases, and in the polystotic one, they're 50%. So there's also a type, there are various types, various diseases where this happens. One of it is McCune-Albright disease, where the signs and symptoms are polyostotic bone lesions, caffeole spots, endocrine pathologies like there is precarious puberty, acromegaly, hypothyroidism. Also, the mean age involvement is 8 years. So, out of this, usually 90% show skull base out of the the craniofacial bones, when they occur, out of this 90% cases are of craniofacial and 95% of skull base. Also, temporal bone, there's 70% cases. So, in this, the methodology, a retrospective descriptive study was done. The examining points were patient characteristics as the age, gender, major history, clinical presentation, the radiological imaging, basically CT scan, pathological data, that is histopathological examination, and progression of the disease. So in diagnosis, again, like a single or multiple bones could be involved. Facial asymmetry could be there. Histopathologically, bony trabecula and spindle cells are seen. Also, there could be other signs and symptoms like nasal obstruction or change in visual acuity. So there are multiple cases in this. The first case is 13-year-old female, where she had proptosis of the right eye, and there was nasal obstruction and swelling on the right side of the nose. There were no visual symptoms. CT scan showed ground glass attenuation, and also there was scalloping of the medial and inferior bones of the orbit. Plus, so the lesion was pushing and occupying the orbital capacity. Also, so a functional endoscopic sinus surgery was done for the excision and was went for HPR, which was suggestive of fibrous dysplasia. So these are the before and the after photos of the of the patient. So there was also the case too, where 20-year-old female presented with infraorbital swelling of the of the left side, and she was already a known case of type 1 neurofibromatosis. There was similar ground glass appearance of 3 by 4 by 2 centimeters on the left side. Plus, similarly, a maxillary sinus endoscopy was done, and plus left sublabial exposure was done, and HPR suggested of fibrous dysplasia. The same patient came with a recurrence after about 1 year, and she presented with similar complaints of swelling on the left side. Plus, there was watering of the left eye. So, revision surgery was done, and before that, on a revision CT scan, there was amorphous calcification, okay, and with curvilinear peripheral amorphous calcification. She underwent a revision surgery and also went endoscopic DCR. So these are the changes. These are the photos of the patient. This is the first time she came. That's after the surgery, and that's 2 months after the second surgery, the third photo. Similarly, this is of a 16-year-old male patient. He complained of a swelling on the right side, infraorbitally. There were no visual complaints. A similar picture was seen, and this involved the right maxillary sinus. Also, the alveolar process, ethmoid bone, and the sinus greater wing. He underwent a similar surgery, but with external approach, and HPI was suggestive of fibrous dysplasia. And this was a 9-year-old male boy. He had complaints of similar complaints: left side swelling and left eye proptosis since 4 years. In this, there was involvement of a lot of bones, like left zygomatic, left sphenoid, left frontal, left maxillary. But since there was no visual complaints, and also the left optic canal, in MRI, the left optic canal, left superior and inferior orbital fissures was spared. So there was no surgical intervention that was performed. This is a 25-year-old male patient, localized swelling bilaterally in the maxillary and mandibular area. Also, there was proptosis of the left eye. And there was a multidisciplinary approach performed for this patient. So, in conclusion, what we can conclude is CT scan is the mainstay. There is usually very less role of medical conservative management. Surgery is the mainstay treatment that is done for such patients. A multidisciplinary approach is usually opted for, and the operation or the management procedure is planned according to the complaints of the patients, the age of the patients, and what they decide, what they opt for. Thank you so much. Thank you so much. Thank you.
I would request Dr. Balaji Mane sir to hand over the certificate to Dr. Mandira Patil. Next, Dr. Megha Prabhash.